idiopathic thrombocytopenic purpura, which is recently known as autoimmune thrombocytopenic purpura, ودائما احنا نختصرها ITP. It is the commonest cause of thrombocytopenia in an otherwise healthy child, caused by platelet destruction by autoantibody directed against the platelet surface that occur 1 to 4 weeks after exposure to viral infection. Few words about pathogenesis. The exact antigenic target for most such antibodies in most cases of childhood acute ITP remains undetermined. Although in chronic ITP, many patients demonstrate antibodies against alpha-2b and beta-3 and GP-IB antigen, they are surface antigen on the platelet surface. After binding of the antibody to the platelet surface, circulating antibody-coated platelets are recognized by the Fc receptor on splenic macrophages, ingested and destroyed. Most infectious viruses have described an association with ITP, including EB virus, Epstein-Barr virus. Usually it is of short duration and follow infectious mononucleosis course. And HIV, usually chronic. ITP appear to arise in children infected with Helicobacter pylori infection and rarely following vaccines. فهسه احنا شفنا انه ال H. pylori related to ITP, related to iron deficiency anemia, and also it is found to be related to ischemic heart disease. We can classify it into acute, where the platelet return to normal count of 150,000 per cubic millimeter within the first 3 months after diagnosis, and relapse does not occur. Persistent from 3 to 12 months. Chronic, where the platelet count remain low beyond 12 months, and usually this is noticed with older children who have altered immunity. Recurrent, the platelet count decrease after return to normal level. Concerning the clinical feature, the usual age is between 2 and 6 years. Male and female are equally affected. It is more in springs and usually preceded by viral upper respiratory tract infection in 80% or vaccination 1 to 4 weeks prior to the illness. The usual manifestation is generalized petechiae purpura ecchymosis in a completely healthy child. Gum and mucous membrane bleeding can also be noticed. In 1%, intracranial hemorrhage may occur, usually in the first days or weeks of the disease when the count is less than 20,000 per cubic millimeter. Usually, retinal hemorrhage precedes and predicts the occurrence of intracranial hemorrhage. There is no pallor unless there is massive bleeding. There is no hepatosplenomegaly and no lymphadenopathy. The presence of organomegaly and lymphadenopathy usually suggests leukemia. When the onset is insidious, chronic ITP and SLE should be excluded. In 70 to 80%, acute ITP in children resolved within 6 months, and therapy does not appear to affect the natural history of the illness. 20% of children with acute ITP may pass into chronic ITP. Assessment of the severity depends on the signs and symptoms, but not on the platelet count. The first group, no symptoms. The second, mild symptoms with bruises and petechiae, occasional minor epistaxis, very little interference with daily living. Moderate, more severe skin and mucous membrane lesion, more troublesome epistaxis, and menorrhagia. Severe, bleeding episodes such as menorrhagia, epistaxis, and melena usually severe enough to require transfusion mainly and hospitalization, and the symptoms usually interfere seriously with the quality of life. The lab finding, of course, the platelet is low. In general, it is less than 20,000 per cubic millimeter. Their size either normal or large. The white cell count normal with mild eosinophilia. Normal hemoglobin, unless there is severe bleeding where the hemoglobin is low. The bone marrow normal or there is increase in the megakaryocytes. Normal myeloid and erythroid series with eosinophilia and erythroid hyperplasia. The bleeding time is prolonged while the PT and the PTT are normal. This blood film reveal giant platelet, which is usually seen in thrombocytopenia, and slide B is a bone marrow show increased number of megakaryocytes. The indication for bone marrow aspirates is, first of all, presence of abnormal white cell count or differential count, unexplained anemia, and finding suggestive of bone marrow disease on history and physical exam. For the time being, usually we start treatment depending on the peripheral blood film and the platelet count, and not do bone marrow aspirate routinely. In adolescent with a newly diagnosed ITP, anti-nuclear antibody should be done to exclude SLE and HIV done study in at-risk population. Coombs test should be done if there is unexplained anemia to rule the Evans syndrome, which is a combination of autoimmune hemolytic anemia, thrombocytopenia. Differential diagnosis should be done from drug-induced thrombocytopenia. It means a drug-dependent antibody, splenic sequestration due to previously unappreciated portal hypertension, leukemia, aplastic anemia, Fanconi anemia, megakaryocytic thrombocytopenia, thrombocytopenia abscess, hemolytic uremic syndrome, DIC, SLE, HIV infection, lymphoma, Wiskott-Aldrich syndrome, platelet dysfunction, and von Willebrand disease. What about the treatment? If the condition is mild, no therapy other than education and counseling of the family and the patient for those with minimal, mild, and moderate symptoms. And no treatment is applied when the count is more than 35,000 and the patient is asymptomatic. The drug of choice if you want to start treatment is the intravenous immunoglobulin, IVIG. The usual dose is 0.8 to 1 gram per kg per day for 1 to 2 days. This will cause a rapid rise in the platelet count more than 20,000 in 95% within 48 hours. And it is indicated if there is mucous membrane bleeding, which is known as wet purpura. IVIG appears to induce a response by down-regulating Fc-mediated phagocytosis of antibody-coated platelet. It is expensive and time-consuming and requires hospitalization because it is given by IV infusion. And after infusion, the main side effect is the high frequency of headache and vomiting, suggestive of IVIG-induced aseptic meningitis. The second line is intravenous anti-D therapy, usually used when the patient is Rh positive, in a dose of 50 to 75 microgram per kg. Also, it will cause a rise in the platelet count more than 20,000 in 80 to 90% of the patient within 48 to 72 hours. When it is given to Rh positive individual, IV anti-D induce mild hemolytic anemia. The RBC's antibody complexes bind to macrophage Fc receptors and interfere with platelet destruction, thereby causing a rise in the platelet count. It is ineffective in Rh-negative individuals. Prednisolone is the oldest and the cheapest type or line of treatment which have been used for many years for acute and chronic ITP, whether in children or adult, in a dose of 1 to 4 mg per kg per 24 hour for prednisolone. It appeared to increase the platelet count than in untreated patient, whether bone marrow examination should be performed to rule out other causes of thrombocytopenia, especially leukemia, before institution of prednisolone therapy in ITP still controversial. The course should be given for 2 to 3 weeks or until there is a rise in the platelet count more than 20,000, with a rapid taper over a period of 1 week to avoid the long-term side effect of steroid, especially growth failure in children, diabetes mellitus, and osteoporosis. Each medication may be used to treat exacerbation, which may occur commonly several weeks after an initial course of therapy. In special cases of intracranial hemorrhage, multiple modalities of treatment can be used, including IVIG, high-dose steroid, and even platelet transfusion, and sometimes emergency splenectomy. The role of splenectomy should be reserved for older children who are more than 4 years of age with severe ITP and mainly chronic, lasting for more than 1 year, and who has symptoms that does not control with any line of therapy. The second indication, when there is life-threatening hemorrhage such as intracranial bleeding, massive GI tract bleeding, massive epistaxis that complicate acute ITP, and the platelet count cannot be corrected by the usual mode of treatment, IVIG and steroid, or as well as platelet transfusion. Rituximab have been used as an alternative to splenectomy. It induces partial or complete remission in 30 to 40%. Another alternative is high-dose dexamethasone pulse therapy. Thrombopoietic receptor agonists increase platelet count and approved to be used in pediatric, including L-Thrombobac and romiplostim. They compensate against platelet destruction and maintain platelet count more than 50,000. This table shows the different lines of treatment with their pros, cons, and costs. Concerning the prognosis, in 70 to 80% recovery within 6 months, 50% they recover within 1 month. Spontaneous remission is unlikely after 1 year, but may occur after several years. Few words about chronic ITP. Approximately 20% who present with acute ITP may have persistent thrombocytopenia more than 6 months. Splenectomy here is successful in inducing complete remission in 64 to 88% of children with chronic ITP. Before splenectomy, the patient should receive a pneumococcal and meningococcal vaccine, and after that should be given prophylactic penicillin for years or for life. Thrombopoietic receptor agonists increase platelet count and approved to be used in pediatrics, such as L-Thrombobac and romiplostim. They compensate against platelet destruction and maintain the count more than 50 times 10 to the power 9 per liter, and they can be used as a line of treatment before doing